Over to you, Dr. Shah.
Thank you. Thank you, Hitesh. And thank you for giving me the opportunity to have talk on this. So I'm going to talk on the Ponseti methods of clubfoot management. The thing is change in the orthopedic dramatically from operative to non-operative is one clubfoot management. It's because of the Ponseti's long-term result of the clubfoot casting. And he made the people to understand that the manipulation and casting gives better, superior, simpler, faster result than the surgical intervention. So it is very easy. One can learn is a simple, easy, and fast and effective technique is a Ponseti method of the clubfoot management. So I'm going to cover the few parts on my talk. Important is that the type of the clubfoot, all feet are not same. All the clubfoot are not same. So we need to identify what are the clubfoot types, various deformity and simplification of the deformity, how to identify the hindfoot deformity and the forefoot deformity. What is the aim, primary goal of treating of clubfoot? Few technical details of the Ponseti manipulation. Cover few parts of the atypical clubfoot, and many times people will get confused with the typical and atypical clubfoot. Common errors while doing about the Ponseti methods, the limitation of the manipulation, because no technique in the world can give the 100% results. And that is the reason I will say how to avoid that. Very common is the primary idiopathic clubfoot. So when it happens that is without any associated syndrome or secondary problem, it will be the primary idiopathic clubfoot. And what are the things on the secondary clubfoot? Very common to have the spina bifida. So always look at the clinical examination of the spine, tuft of hair or the palpable defect on the back to find out whether it is associated with the spina bifida or spinal dystrophism. Very common congenital clubfoot would be associated with the arthrogryposis, multiplex congenita, or another name, recent name is multiple congenital contracture. If it is there, one of the secondary causes like spina bifida or arthrogryposis multiplex congenita, the result of the manipulation would be different than the idiopathic clubfoot. So it is better to identify before beginning of the treatment. And very rarely we will find out the associated syndrome like Larsen syndrome, diastrophic dysplasia, Mobius syndrome, Freeman-Sheldon syndrome, or tibial hemimelia, where the clubfoot treatment would be totally different. It may be associated with the laxity or it may be associated with the stiffness of the foot. So it is important to find out the primary clubfoot. My talk would be related to the primary clubfoot, not about the secondary clubfoot. Second part is what are the deformity of the clubfoot. The deformity of the clubfoot would be the hindfoot deformity and the forefoot deformity. The hindfoot deformity would be hindfoot equinus and hindfoot varus. So how to identify the hindfoot equinus and hindfoot varus? Hindfoot equinus would be easily identified by the heel is pulled up because of the strong Tendoachilles, and clinically it is appreciable by if you draw from the side of the foot, the axis between the tibia and the foot will make the angle more than 90 degrees. Normally in a plantigrade foot, it will be 90-degree angle between the tibial axis and the foot axis, which would be more in case of the hindfoot equinus. It is better to identify such deformity along with the posterior crease and the empty heel sign in case of the hindfoot equinus. Second deformity is of the hindfoot is the hindfoot varus, where the heel is deviated medially. And if you see the normal side, the heel is bisecting the calcaneum, and that or little valgus would be present on the normal side. When in case of the clubfoot, the heel is deviated on the medial side. and that is because of the deformity of the subtalar. So the hindfoot equinus happens at the tibio-talar joint at ankle joint, and the hindfoot varus happens due to the adduction, inversion, and plantar flexion of the subtalar joint. So the hindfoot deformity would be best visible from the side and back. Another commonest deformity of the forefoot deformity. What are the forefoot deformity in the clubfoot? That is the forefoot adduction, and cavus is the commonest deformity in a clubfoot. So how to identify the cavus? When the medial longitudinal arch of the normal child would be looking like this in the longitudinal line of shown in this picture, while the first ray would be plantar flex compared to this line, that is the cavus. When there is an exaggerated longitudinal arch, it will be called as the cavus deformity of the foot. And it will be also visible like that when the first ray is pronated and lateral rays touches the ground. If we can see the medial side, there will be decrease, and there is a persistent plantar flexion of the first ray would be there. And these are the deformities. It's very important to identify to avoid the iatrogenic or the resistance clubfoot or the Ponseti treatment. Third important aspect is the forefoot adduction. When we see about the forefoot adduction, medial and lateral border are not the same. Medial side would be concave and lateral side would be convex. And these are the very important deformity of the forefoot. So forefoot adduction and forefoot cavus deformity would happen in the mid-tarsal joint. That is a talonavicular joint and calcaneocuboid joint. There is a difference between the forefoot adduction due to the clubfoot and metatarsal adductors. The deformity happens in metatarsal adductors at the tarsometatarsal joint, and deformity in the clubfoot happens at the mid-tarsal joint, that is the calcaneocuboid and talonavicular joint. So whenever we see the child with the clubfoot, we need to identify what are the deformity of the foot, whether it is a hindfoot equinus, hindfoot varus, forefoot adduction, forefoot cavus, or the pronated foot, or everything would be there in this child. The important aspect of the Ponseti has described that in the paternatomy, understood very well by where is the deformity. It happens at the tibio-talar, and the ankle joint is in plantar flexion. Then there is a wedge-shaped talus as well as the navicular. Navicular is displaced medially compared to the head of talus, and the calcaneum is adducted plantar flex and medially compared to the talus because of the subtalar varus. And that is very important associated with the cavus deformity. The first metatarsal is plantar flex and medial exaggerated arch is present. When we are going to treat the child with the clubfoot, we need to identify what are the deformity in the clubfoot. The Suffolk Pirani has identified and put into simplified into the quantification of the hindfoot deformity and the forefoot deformity. The hindfoot deformity is divided into the posterior crease, the antiheel, and rigid equinus. So whenever it is all 6 scores, and the 3 hindfoot score and 3 forefoot score has been given to identify what is the severity of the deformity. 0 has been given where there is no deformity or absolutely normal foot, then it will be 0. And 1 is given for the good or the complete deformity would be present. So if we not find the posterior crease, it would be 0. When there is a deep crease, it will be 1. Then there is a faint line, it will be 0.5. Similarly, when you can able to palpate the calcaneum, that would not be empty heel sign, it will be called as 0. And if you cannot able to palpate the calcaneum on the heel, then it is a positive empty heel sign, it will be 1. When we do about dorsiflexion in rigid equinus, we cannot able to do any dorsiflexion, then it is a 1. While that if patient can able to do the passively dorsiflexion, that will be more than the neutral, that will be called as 0. And one can achieve into the neutral or the 90 degree between tibial axis and the foot axis, it is comes to 0.5. There are three midfoot scroll on that. That is the medial crease, the palpation of the head of talus, and the curved lateral border. Similar to the hindfoot crease, when the crease is deep-seated, it will be given a 1. When the deep is not present, it will be called as 0. When the head of talus is palpable and prominent, it will be called as 1. Where it is not palpable, it is normal in position, it will be called as 0. Similarly, lateral border is convex. It will be called as the 1. It is not touching in the lateral border at all to the straight border, then it is 1. While it is touching lateral border of the foot is touching the straight border, it would be called as 0. If the partially the forefoot is touching on the straight border, it will call as 0.5. So every clubfoot deformity, whether it's unilateral or bilateral, before correction or after correction, it is mandatory to find out what is the Pirani score. It varies from 0 to 6. If it is 0, means the foot is completely corrected, and 6 means that all the deformity of hindfoot and midfoot deformity would be present. It is mandatory to correct the, everybody knows the forefoot deformity should be corrected first. So when it is necessary, when we do decide about the Tendoachilles tenotomy, the forefoot deformity or the midfoot score should be 0 or 0.5 before contemplating about the Tendoachilles tenotomy in Ponseti manipulation. What is the goal of treating about the clubfoot is to get the functional, pain-free, plantigrade, mobile foot, and it will be acceptable to the patient and the family. To achieve that, it is, as I said, that specific method of the manipulation in a sequential order should be done, and it's important to use the talus as a fulcrum. And most of the cases in Ponseti manipulation, around 95% will require the Tendoachilles tenotomy at last. When to start the Ponseti manipulation or the plaster manipulation, it should start as early as possible. Many people were worried before because of the softening of the skin and the neonate skin, but ideally it should be considered, it should be start within a week of the child's birth. What is the reason why should start it early? If you start it early, less number of casts would be required and deformity would be supple. We can easily correct itself. How frequently we need to change the cast? It should be change the cast every 5 to 7 days. The endpoint of the plaster technique must be the full correction. What is the order of correction is there? The Ponseti described in his classic methods is there is a cave. Cavus should be corrected first, followed by adduction, then the hindfoot varus, and the last is the hindfoot equinus. What is the reason to follow the specific sequences there? If we try to correct the hindfoot equinus first, we can land up in the secondary deformity like a rocker bottom foot. So it's always to consider for the cavus, followed by adduction, followed by varus, followed by equinus. And this, the model will give you the idea how can we correct it. The first correction at the first presentation where the cavus is corrected, followed by that, we can able to abduct then do about the forefoot correction. After that, the more abduction can lead to the hindfoot varus correction. And at last, we can do about the hindfoot equinus correction by the Tendoachilles tenotomy. The first and foremost is to find out the cavus. And if you see about the schematic presentation of the right side of the foot, the first metatarsal is plantarflex compared to the fifth metatarsal, and that is the cavus. In other sense, Ponseti said is the pronated first metatarsal. So what he suggested is to lift the first metatarsal and make it into in line with the fifth metatarsal. That is called as the supination. So The pronation of the first metatarsal would be corrected by easy and simplest method to lift the first metatarsal. So if you see about the foot model on that, there is the hind foot and the forefoot. We will lift the first metatarsal. The fifth and first metatarsal come in the same plane, and that is the simplification of the Cavus correction. It will be very easily corrected by lifting the first ray. Like this is the first step on correction of the Cavus, the lift of the first metatarsal. And when we are doing about lifting of first metatarsal, we need to keep our thumb on the head of talus. How to palpate the head of talus? It is very easy to palpate the lateral malleolus. Just anterior to the ankle, we can palpate the head of talus, and we need to give the fulcrum at the head of talus in order to prevent about the ankle mortise or the displacement of the calcaneum talus, to prevent the external rotation deformity, because we are going to correct first the cavus, followed by the abduction, and followed by the external rotation. So in order to prevent, that is the basic principle of the Ponseti method. So lift, this is the side view, is there just a lift of the first metatarsal to correct the cavus. The very simplest method is to correct the cavus by lifting the first metatarsal. And many times for the laymen and parents, deformity appears to be more when we increase about supination, because the hind foot would be already there in varus and equinus. So when we keep the forefoot in align with the hind foot, sometimes it will be appearing more, but we need to reassure on the first metatarsal. Very simplest method, when we try to do about the pronation, you can see that the cavus is exaggerated, and according to the Ponseti, and this must be avoided. You should never ever pronate the first metatarsal. The correct way is to just lift. You just lift the first metatarsal in order to correct the cavus, and the foot appears normal. Sole side, it looks normal. The second step or the second manipulation after the correcting about the cavus is to do about the adduction and varus, and sequential correction for the second, third, fourth plaster, with doing about correction about the forefoot adduction and varus. What is the basic principle behind that? We will utilize about the head of talus as a fulcrum rather than as calcaneocuboid. What Ponseti may mention is the kite's error. What he utilized the fulcrum as the head of talus rather than putting the hand thumb on the calcaneocuboid. What the kite utilize the calcaneocuboid for the forefoot correction, but if we try to continue that, it will prevent the correction of the hindfoot varus. And that is the reason the fulcrum has changed from the calcaneocuboid at the calcaneum to the head of talus for the step 2 correction of the forefoot adduction. So when you see about the dissected specimen is there, when the head of talus is visible on the red and all the tarsal bone is visible on the yellow. So the navicular is shifted, it's medially. So, and rest of the foot follows the navicular. So we need to align the talonavicular normally by keeping the foot into abduction, and we try to abduct the forefoot by putting about pressure on the head of talus. And that's why you need to do about the forefoot adduction correction by abducting. This is the way when we are going to hold the foot on the cavus correction and putting the thumb on the head of talus and try to correct that. So this is that is a sequential correction, and ultimately we need to get about the correction about the 70-degree abduction in order to get it the correction of the forefoot as well as correction of the hindfoot. The important aspect of this manipulation is that you should never ever pronate the foot while doing about the manipulation. The most senior person do about the manipulation for 30 to 40 seconds. Following that, they can apply about the soft roll and plaster after application of manipulation for 30 to 40 seconds. Manipulation would be followed by casting, and casting should be done to maintain the correction. The soft tissue stretch done by the manipulation would be maintained by the plaster. So the plaster technique, whenever we are going to use that, our hand should not be giving pressure on the head of talus. We try to move the head from one position to other position to prevent the pressure sore on the talus. And the important aspect is the tactile experience or the sensation for the head of talus, and the visible deformity is the cavus. That must be corrected. And once the forefoot is corrected, automatically the hindfoot will follow on that. So in second, third, fourth manipulation, we try to correct about the forefoot abduction. And in those manipulations, sequential manipulation, never ever pronate the foot. Never ever try to do about the pronation of either the first metatarsal or pronation of the hind foot. This will be the looking like plaster after third or fourth manipulation. The basic principle is there whenever you just do about the lifting of the first ray, and after second manipulation, you try to use the thumb on the lateral side of the talus and do about the abduction, gentle abduction. It looks initially the forefoot correction, and following after that, we can able to see the hindfoot varus gets corrected. If you see the schematic presentation, the talus and calcaneum, talus is visible on red and calcaneum is visible on yellow, and the rest of the tarsal and the metatarsal is looking on the green. When we do use of the fulcrum on the head of talus, first initially it's correcting about the forefoot adduction. Following that, we continue to abduct that, it will correct the hindfoot. So the hindfoot varus will get corrected by doing about the abduction. Every cast should be kept or put in the OPD without anesthesia. It should be without any sedation, and every cast should be done in the above knee cast in a 90-degree knee flexion. Generally, it is required to do about the 90-degree knee flexion in infant or child younger than 1 year in order to avoid the slippage of the cast. If we try to do the older kid, we can keep the knee in less flexion around 40 to 60 in order to make the child walk with the knee in less flexion. If we keep the knee in a 90-degree of flexion, child cannot able to walk on that. So these are the sequential cast on that. There's the gradual forefoot adduction. That first cast is the cavus correction. Following that, it is from the visible from front and side. Forefoot correction. Following that, there is hindfoot varus, and the last cast would be there in either. After that, it will be as hindfoot varus gets corrected, the forefoot is automatically going in abduction, as well as the hindfoot equinus inversion gets corrected, hindfoot varus correction, and the last would be for the hindfoot equinus. The step 3 would be the correction of the hindfoot equinus. The most of the children will require about the Tendoachilles tenotomy. And why the Tendoachilles tenotomy is necessary? Because the hindfoot equinus is related to the strongest muscle in the body is the Tendoachilles, and it tends to pull the calcaneum up. And if we try to do the manipulation in order to correct the hindfoot equinus, we can land up into the secondary deformity, and it can lead to the rocker bottom foot. And iatrogenic, we can do about the make the another deformity, and it is difficult to correct this deformity. Rather than that, we can utilize the simplest surgery, tenotomy, because in a child it regenerates very well.
So when should we do? Ideally, midfoot deformity should be 0, but it can be acceptable in some case 0.5 to 1. And hindfoot score should be more than 1. If hindfoot score could be 0, no need for doing about Tendoachilles tenotomy. That is rest 5 to 10% of the case.
What is the goal of doing about Tendoachilles tenotomy? We need to get at least 15 degree of the ankle dorsiflexion in order to get rid of empty heel side and in order to correct about hindfoot equinus. So what is a Tendoachilles tenotomy? This is the OP procedure and depends on the comfort zone of the surgeon. It can be done in relaxed style either in local anesthesia or general anesthesia. But the principle wise that we can able to cut the Tendoachilles tendon from medial side to the lateral side, and we can able to dorsiflex the ankle joint, not at the mid-tarsal joint. Deformity happens at the tibio-talar joint, so we can able to dorsiflex at least 15 degree after the Tendoachilles tenotomy. Technique is very, very simple. It should be the relaxed child in the OP or theater. It should be done with the needle. It can be done with the number 11 blade, or it can be done with the beaver's blade. It can be done from the medial to lateral side. Why medial to lateral? That is the most important structures. The neurovascular would be present on the medial side. So it's medial to lateral is simple, but there are reports that we can able to cut about the lateral side of the peroneal vessels. So we need to be careful on that. How it should be done, the Tendoachilles tenotomy should be done with keeping the mind that we should enter from the anterior to the Tendoachilles. When we go in the deep to that, we can able to change about direction of the blade from the medial to lateral. We should enter from anterior and go from medial to lateral. And the complete transaction of the Tendoachilles would be heard and felt. It's important it should be done in the infants. In older child, that is a controversial subject. How long we can able to do about Tendoachilles tenotomy for the correction of the hindfoot equinus? The most commonly, it should be done and easy and safe, 2 years of age. Still reports are there. We can able to correct in an older child also. At end of the plaster after the tenotomy, satisfactory correction should be looks like this. What is the protocol following the
Tendoachilles tenotomy? The post-tenotomy,
the above cast should be maintained for the 3 weeks in the 15 degree of the dorsiflexion at the ankle joint and 70 degree of the abduction. Most important aspect of the Ponseti manipulation or Clubfoot manipulation is the correction of the deformity and maintenance of the correction. The result would be excellent only if we can able to maintain the correction obtained by the serial manipulation and casting followed by the tenotomy only by the foot abduction orthosis. It is important to use the brace that is used as the dynamic brace. It is used in the child in 23 hours in a day, and it should be till its walking age. What is the measurement of the foot abduction orthosis? The bar size should be equal to the distance between the both shoulder of the child. The size of the infant varies from the different size. So it will be depends on the availability of the brace. It should be kept as the foot abduction brace. What is important aspect for the care of the child in the foot abduction brace is that ensure that the heel is touching the sole. And it's important to tie the strap on the ankle. And while tying the strap of the ankle, the heel should be touched on the sole. And same time, when we can able to identify the back of the medial side or the posterior side, we can able to visualize that whether the heel is touching, because the most important aspect that we need to maintain about the hindfoot equinus correction in the child with a splint. Foot abduction splint should be wear up to the night time after the walking age, and it should be continued for the 3 to 4 hours. When should we discard the foot abduction orthosis? when child can able to actively abduct and invert the foot, and those child we can able to discard the foot abduction orthosis. Many of children may develop the dynamic supination or the dynamic inversion because of the tibialis anterior overactivity, and those children may require the split tibialis anterior transfer or complete transfer of the tibialis anterior on central transfer. I will address that also later. The important to find out how many plasters would be required, because the parents would be asking how many casts would be required to correct the deformity of the clubfoot. It depends on the age of the patient. Younger the age, less number of the casts; older the age, more number of the casts. Severity, the severity of the foot, all deformities would be present. All deformities would be severe. Like if you see the hindfoot and forefoot score, both are very severe. The Pirani score is 6. The number of casts will require more compared to Pirani score 3. Soft tissue tightness, if there is the suppleness in the foot would be there, then it will require the less number of casts. Rigid deformity will require more number of casts. This is the example where we can able to see all the deformities there. In the first plaster, we can able to correct about the cavus. After that, we can see it is quite straight and forefoot abduction gets corrected. After that, we can able to do about the external rotation. And after tenotomy, we can able to see the child has got the complete correction of the clubfoot, and it's visually looking a normal looking feet. There's another child where the clubfoot would be there. The child is looking from the side. It's convexity on the side. The child has appeared after the first plaster, the forefoot, the cavus corrected first on the first plaster, and this is the X-ray after the fourth plaster, and it looks reasonably okay on the external rotation. And after tenotomy, it is after the AT has been followed. The long-term result of the serial manipulation and casting is excellent, and this child has got the good correction about the forefoot and the hindfoot here. Few points on the atypical clubfoot. There is it is important to find out the atypical clubfoot. What is actually the atypical clubfoot? When we can find out the short metatarsal. The metatarsal is extremely short, whereas the hyperdorsiflexion of the MTP first ray, when there is a deep crease through and sole, that is not only on the medial aspect, it is on the plantar aspect, and all the metatarsal are the plantar flex. Those are the clubfoot are the more difficult, more complex, and it's atypical clubfoot. In the Ponseti manipulation, we found less than 2% of the total population would be the atypical clubfoot. Sometimes it would be present in some of the chubby kids where the plaster tends to come out because of the more padding, very heavy padding. Then it is possible to patient may develop about the because of the slippage of plaster, the complete plantar flexion of the forefoot. The difference between typical clubfoot and atypical clubfoot. In typical clubfoot, it would be only the first ray would be plantar flex. In the atypical clubfoot, entire forefoot is plantar flex, and that would be the deep crease would be there. The first metatarsal would be short, and MTP is dorsiflex. Those are the most difficult one to correct that. Those will require a little more plaster than compared to typical clubfoot. How to get it corrected is there. When we are in typical clubfoot, we can correct the cavus by lifting the first metatarsal. When we lift about the first metatarsal, still the lateral rays would be plantar flex. So the two hand technique or the two finger techniques would be present to correct about this deformity. We need to do about the pressure on the first and the fifth metatarsal to correct it. It is related to the deformity of the forefoot at the tarso-metatarsal joint. Those deformity we need to correct by lifting the first metatarsal and fifth metatarsal and get rid of the deep crease on the plantar aspect. Then only we can able to correct it. Many times it may be related to the edema and the short stubby foot. The foot looks shorter than the normal child, and that would be considered as the atypical foot. That can be corrected by lifting the first and fifth metatarsal. And once it is corrected, once we are get rid of the crease on the plantar aspect, we can able to do about this, continue the same manipulation and correct with the Tendoachilles tenotomy. Correct the plantar flex metatarsal. These are the most important points. This is the same child after the correction of the forefoot equinus, and it can be corrected with the abduction. And this is the after tenotomy. You can able to see there is a complete good 15-20 degree of the dorsiflexion and follow. It is maintained with the abduction orthosis. Few points on the limitation of Ponseti. It is rare. I like to say that 95% will get the good result with the serial manipulation and casting. But it is also important to understand the 5% where we are not getting a result. What is the reason for that? If we are getting the navicular is getting is fixed, that would be this correction. If there is a talonavicular bar or maybe the synchondrosis or cartilaginous bar or maybe the fibrous bar, or there is no movement of the talonavicular joint, and if you try to do about that, the navicular would not get corrected and we'll have false sense of the correction on that. It will be very common in the syndromic foot. Similarly, when there is a fixed subtalar, there is a false correction. When we are going to do about the abduction, we can able to abduct the foot, but beyond some time, the hindfoot varus will be persistent. So we need to find out whether it is suppleness of the subtalar is present or not. And that is the reason we need to find out whether the child has got the primary clubfoot or a secondary clubfoot. This would be very much visible in some of the secondary clubfoot. But the most of the cases will be corrected with the serial manipulation and casting on that. But this is the difference between, if you see the difference between the right side and left side, when do about the abduction, we can able to correct about the forefoot adduction and the hindfoot adduction, the hindfoot varus. Well, in fixed subtalar, we can able to correct about the forefoot, but we cannot able to correct about the hindfoot correction. Few points, technicality of the common error, which is done by the most of the people. It must be avoided. We must know, we must learn this, that what is those error. The persistent cavus because of not elevating the first metatarsal or pronating the first ray. We should never ever pronate the first ray. Correct the first metatarsal, correct the cavus by just lifting a simple first metatarsal. And never ever in any first, second, or any manipulation, never ever try to do about pronation or the eversion. Many times, many of the old concepts say it is the inverted foot. So you need to do about eversion. No, we need not to do about the pronation or eversion of the foot. Third important aspect is that premature attempt at the dorsiflexion foot to correct about hindfoot equinus. Don't try to do about the severe rigid manipulation in order to correct about the hindfoot equinus. We may land up in the rocker bottom foot on secondary deformity. Every single child must be followed. Ideally, it should be followed till the skeletal maturity. If it is not, it should be followed till there is an active abduction and eversion will be present. Dynamic forefoot abduction, can lead to that adduction can be present because of the tibialis anterior transfer. It can be due to the tibialis anterior transfer. There is a controversy in the literature till what age we can use about the Ponseti. More and more people try to use. Initially, it has been utilized in infant and 2 years and 3 years, but now there is no upper age limit. More and more publication has come in a older age group, 10 years, 12 years, including 16 years. But beware that the number of casts will require would be more, and the compliance would be another issue. Does the age at beginning it makes difference? Yes, it makes a difference. Early the age, we can get the good correction. Later the age, it will take a little more correction. I like to put into that the key points on the Ponseti is there. The sequence of the correction is important. Always remember the Cavus, adduction, varus, and equinus. That is very important. Salivate, the first metatarsal, supinate the forefoot in order to correct the broad cavus. The counter pressure or fulcrum would be used at the lateral part aspect of the head of talus. The varus corrects with the abduction, and the tenotomy is required in the most of the cases. Thank you for the listening. I'd like to answer any question if you have that. Thank you.
Thank you, Dr. Shah, for that brilliant presentation. You have covered almost everything, and it was a great honor to have hosted you here. There were not many questions, actually. They've all liked your presentation, and they all messaged me that it was very comprehensive and they could understand everything. I have a question. Is there any contraindication where you should not do a Ponseti?
No, it is not any contraindication. We can do about the Ponseti manipulation for the most of the cases. In fact, the secondary clubfoot, we can treat with the Ponseti manipulation, but we need to understand the limitation of the Ponseti manipulation or the methods for the secondary clubfoot. Like if we are going to do about the spina bifida, we need to check about the sensation, we check about the motor power, we need to check about the actual imbalance between inverter and everter. In those cases, if we are not very much aware about the secondary problem of the spinal disruption, we'll end up into making into tropical ulcer. And we'll see that is because of the poor padding of the child. It doesn't mean we need to do about the lot of padding. Even in the spina bifida, the padding is almost the same like the normal clubfoot, but the surgeon should be experienced enough to put the pressure equally distributed all over the foot in order to prevent the trophic ulcer. Similarly, when we see about the multiple congenital contracture, 30 years back, the concept was there is a contraindication we should not do about the Ponseti manipulation. But the more and more reports are coming, even though it doesn't achieve the 90-95% correction, if we can able to achieve the 60%, 50 to 60% of kids with the plaster, it would be much better than the surgical stiff foot. So we can able to do, there is no, in fact, diastrophic dysplasia or the Larsen syndrome, we can able to do about the same. But if the child is having the ligamentous laxity, gross laxity, word of caution for doing about the tenotomy, word of caution of doing about soft tissue surgery. And that is very important. So it is not simple to say every single child will require tenotomy. No, some of children may not require tenotomy if there is associated or the hindfoot correction will be quite good with the serial manipulation.
Okay, so that was a great answer. So, you know what, very commonly people ask this question, like, see, in the first cast, you're correcting the first metatarsal drop, right?
Yes.
And you're exaggerating the deformity. That means increasing the supination, right?
Yeah, it is actually not increasing the supination, just lift the first metatarsal in line with the hindfoot. So the hindfoot is already in equinus and varus, so it will be looking more, but if you see the sole gets corrected. So it is the cavus gets corrected. So In layman, sometimes it looks more, but it is not hypersupination. It is not supination. We can able to correct the first ray drop. That's all.
No, because you need to warn the parents, right? After
Yes.
the cast, it'll look a bit exaggerated.
Yes, but the many times we can able to do about the same time we can able to correct the forefoot also. So then it will not be looking so grossly deformed on that. It depends on the suppleness of the foot. If the foot is quite supple, in the first cast also it looks a little better. Not every single child will have the exacerbated deformity.
And the other question is, what about the last cast? We generally put in slight hyperabduction, right? You need to exaggerate it, right?
Yes.
Okay.
Yes. The last cast should be, according to Ponseti, you can do about 50 to 70 degree about the external rotation, and that we can able to achieve in compared to the tibial axis. Where we have drawn, I have shown in one of the photographs, we can see about the tibia and the foot. The axis would be around the 70 degree. And then only we can think the hindfoot and forefoot both gets corrected, and last only the equinus is left. Then only we can do about the Tendoachilles tenotomy.
Okay. The other thing was regarding the kite management and Ponseti, because even though Ponseti described this technique way back in 70s and 80s, it wasn't accepted for say 20 years.
Yes.
Because the kite lobby, that's what people, I mean, some surgeons said there was a huge kite lobby that promoted kite, and Ponseti couldn't really be implemented. And in fact, Ponseti has written in his in a paper that surgeons always love their little knives. I still remember the statement.
Yes. There are a couple of things on that, the kites and Ponseti. If we want to say about the difference about the kite and Ponseti, number one difference is that kite has never mentioned about the Cavus, number one. So the Ponseti has mentioned about the Cavus. Number two difference is there, the kite has corrected forefoot adduction by keeping the hand on the calcaneocuboid. He used as a fulcrum as a calcaneocuboid. So he put the hand on the calcaneocuboid, while the forefoot adduction in Ponseti is corrected by putting a fulcrum at the head of talus. The third difference is there, the Ponseti never ever evert the foot, while the kite used to do about eversion of the hindfoot. We do the calcaneum on the backside and evert it. And the fourth difference is that kite never mentioned about the Tendoachilles tenotomy, while the most of the cases in Ponseti recommend that you can do about the hindfoot correction by the Tendoachilles tenotomy. But one thing I like to mention here, it is the kite, it is not kite lobby or the Ponseti lobby. The kite used to get around 60% about the good result. And if you see, if we add the, and kite used to correct the hindfoot equinus by the serial wedging of the cast. And he used to do more number of the cast. So as something new comes in market, and if we are getting a 60% result, we don't jump and do about the 90%. As simplest example is at this era is SIP surgical dislocation. People started doing about SIP surgical dislocation, but some people started having conservative. Similarly, SIP surgical dislocation with the head reduction osteotomy. But we don't know. If you read the Western literature, in the slip capital epiphyses, we'll get about the 25 to 40% about the AVN. That is quite high. So that is the both ways. And that time, the society was very, very conservative, where we are talking about 70 to 90. So if we are having good result with 60%, they'll say, okay, we'll go with the 60%.
The other question that is commonly asked among residents for their exam, we have a lot of postgraduate residents, well, just for their benefit, what is the difference between a relapse and a recurrence? I mean, I think it's a common Viva question that is asked for them. Is there a real difference?
It is not actually the difference between that. When deformity corrected and reappear, will you consider as the recurrence. When we can say the resistance, which is not getting it corrected, that is the resistant foot. The relapse and recurrence can be used as a synonyms when it gets corrected and it appears again. Then it is a relapse and recurrence. Basically, for postgraduate, it is important to say typical clubfoot or atypical clubfoot, the primary clubfoot or secondary clubfoot, whether it's a supple foot or a stiff foot, whether it's a corrected foot or not corrected foot, that is more relevant than the relapse and recurrence on that. If the postgraduate can identify this is the primary idiopathic bilateral clubfoot with what are the component of deformity, it would be quite okay. And the simplest for the postgraduate is the simplest answer, because nowadays there are enough literature, and I have not cited any literature here, but there are enough literature. You can have that. If you say that I will do about manipulation and casting following relapse, it would be absolutely correct. If they say the manipulation and casting in the neglected, that is also correct. They will say late presentation, they are correct. They will say resistant clubfoot, still I will use, because that makes some sense. Even though you do about surgery and you do the 1 or 2 plaster, deformity would be little lessen if you put about the plaster. And that is the reason I said it is a very simple. There's a method of serial manipulation and casting. If one can master, they can correct with anything.
Okay. So the other question is, see, when we say atypical, do you mean that when you have a hypoplastic heel or when you have a deep crease, is that what you say as atypical?
Yes, as I mentioned in atypical, atypical clubfoot would be different than typical clubfoot, where we see about the deep crease through and through in sole. There is a short and stubby foot. There are short first metatarsal. There are the hyperdorsiflexion of the MTP, and there is a gross edema would be present. What happened in many of the kid after 2 or 3 manipulation, when we can able to correct the cavus, we can able to correct about the forefoot adduction. After that, what the child is stubby and the plaster slips off. Then plaster slips off. What happened that it doesn't appear at the deformity site at that. It will generate the new deformity at the tarsometatarsal, and entire the forefoot is plantar flex compared to the hindfoot. And that will become the atypical clubfoot. So those cases just require to have lift of the first and fifth metatarsal. And once the deep crease gets corrected, we can correct the rest of things. Many of the surgeon would recommend about the early Tendoachilles tenotomy, but I don't recommend very early in those cases. Reason is there, we can produce the rocker bottom foot on that cases, and that is the reason we need to lift the first and fifth metatarsal correctly before doing about the Tendoachilles tenotomy.
Okay, and what about hypoplastic heel hypoplasia?
The heel hypoplasia, it will be related. It's called as the empty heel sign. It is very common because of the hindfoot equinus. The heel hypoplasia, whenever the heel hypoplasia is there, it is very common in empty heel sign in many of the clubfoot when the severity of the hindfoot equinus is born. So the heel hypoplasia will not be relevant alone, but it would be relevant when there is a foot is hypoplastic, or there would be secondary clawing, and that will give you the idea it is always secondary to the spine deformity, spinal dysraphism or spina bifida. So many times when we see about the very thin calf, very thin leg, very thin foot with the hypoplasia everywhere, it is always secondary, it is always neurogenic in nature.
Okay, Dr. Shah, thank you for that brilliant presentation, and you have covered almost everything relevant. And thank you for sparing your time with us.
Thank you. Hope it will be useful for our students.
Yes, definitely. It has been really beneficial. I can already receive I'm receiving messages on my phone that it has been a very brilliant presentation.
Okay, thank you.
Look forward for more.
Thank you. Thanks.
Thank you. End the meeting.